Okay, we're recording. I don't know if you want to turn your video on, David. I can stop sharing my screen for right now if you want to do an intro or
Sure. It's not letting me because it says you have stopped my video, but maybe I can do it now. No.
let me try to fix that. All right, give it a shot now.
We're good to go. Good to
All
see
right.
you.
Okay, so I am very thrilled to introduce David Yezel. He is an authority on low-dose naltrexone and different alternative treatment methods for chronic pain. He has spoken all over the country to patients and providers and support groups alike. And before COVID, I've never had the luxury of having David join me for a presentation, but a little bit a background about these programs. We have done about half a dozen of these programs over the last year, and we've had some really amazing patient feedback and stories. And I'm excited to have David join us tonight because he brings another level of experience and relatability to this subject. And so I thought it might be nice if David could give some background going introduction here, and then we can talk about an official program here after we get moving. But with that, I'll turn it over to David. Welcome.
Thanks, Brad. And it's interesting. I think it's worth kind of talking about. I've done approximately 200 of these over the last 4 to 5 years. And I think it's always a good way to start is just whether you're a patient or practitioner is understanding why we're here. I find it a very easy way to organize thoughts and, why are we here? You guys are Eastern time zones, so yeah, you are. You 7 at night. And we've done so many of these that you begin to need to answer that question to your satisfaction. And especially as a provider, understanding, why the two major questions I can think of as we talk through these things to keep in mind are, how could a medication such as this be good at so many different things? And the second is sort of, why are we learning about it in this format? This is admittedly unusual. If you're a provider, it's probably the first major medication that you didn't learn about in med school that's not in the Merck manual. Often that creates a sort of a red flag moment. There's a gap in knowledge that we're trying to bridge about the quality of research that's available. And that's where I come in. My background is in biomedical research. I spent a fair amount of time out at Yale Med. I was primarily involved in Parkinson's research and schizophrenia research. That translated into what we used to call mind-body medicine that we now call psychoneuroimmunology. A precursor to functional medicine. And if there was ever a medication that fit into the category of functional medicine, it's LDN. And just as a sort of a background again to that, I feel like very old. LDN makes me feel very old. I've been involved with it for about 5 years. And in that time, I've seen it grow faster than any other part of healthcare that I've ever seen. There's deserved reasons for it. When I began with LDN, there were approximately 200 PubMed articles. There was a fascinating gentleman that we'll be talking about, through the PowerPoint presentation. Dr. Bahari was one of these exceptional, triple-boarded, top 10 in the country at what he did, immunologists. And he made a discovery that very few of us would have made on our own. It's kind of, if you're a history of science person like I am, it's a testament to the power of one individual to notice things that people had missed. So very, very quickly, just as a way to perceive this, naltrexone is a very well-known medication, 40 years old, 10 years out, 40 years out of patent. That's traditionally given between 50 and 300 milligrams. However, if you give it in 1% of that normal dosing protocol, you have almost an entirely different medication that is effective across all these different disease categories. The last count was about 162. So if you're a patient listening, I strongly suspect that one of the conditions that you're here to learn about will be one of the things that there's high quality research attached to. So it was really a revelation, one of those moments where you realize that he observed something that no one else had. And that started this sequence of events where now we have annual conferences regarding nothing but a medication. That's extraordinary. People come from all over the world. Some of the top people out of Harvard, Stanford, Johns Hopkins, Yale, who are all gathered around a medication. And again, there is a need, there's a bridge to be gapped, whether you're a patient or a provider, about, well, how could all these wonderful things be happening and it not be common knowledge, either on a patient side or a provider side? And the reason for that, unfortunately, is something that we call pharmaceutical economics. The way things work in this country is that you typically spend 8 to 10 years developing a medication, you apply for FDA patent, you have a protection period, and then you're able to promote it through traditional channels. That cannot happen with LDN. It is so far out of patent that no pharmaceutical company can recoup their money. And we're left with this, I can't think of another equivalent medication that has as broad base of a use and yet has this intrinsic problem that it needs to be educated in seminars such as this. It needs to be one-on-one with physicians. We have had lectures such as this in about 25 to 30 of the major medical schools. We just finished an opioid documentary involving Yale, Harvard, Cornell, Columbia, and some of the other major medical schools. That was very, very well received. So what we're doing is trying to educate. And I'm a previous research advisor for the LDN Research Trust, where that was our entire goal. It's simply a nonprofit organization dedicated to education about this one medication, because it's truly an extraordinary medication. The reason that I can speak with some degree of experience on this is collectively I've seen about 5,000 patients working through and understanding their dosing needs and the clinical indications they're using it for. But also the ability to speak in terms of what LDN has been in the past and just an explosion of high quality research. So for any practitioner who's listening who believes that they understand LDN, and if your information is more than 2 years old, actually it is to a large degree obsolete. We used to believe LDN was particularly good for autoimmune disease. Now the fastest growing segments over there are things like mental health is extraordinarily good for depression and anxiety. Dermatology is another sort of aspect that we didn't see coming. There's doing chronic pain. And at the essence of all these things is that second question, how can it be good at so many different things? And the answer to that is a little bit complex, and part of that we can go through in the PowerPoints that we'll be talking about. But in essence, it wasn't a designed medication. Medications typically are designed around a symptom. So if you have diabetes, you have an insulin issue, and we develop something that can help you, regulate your blood sugar, and that's it. LDN was something that was discovered largely by accident. Like most, antibiotics were simply a bit of an accident. Many of the major advances in medicine are simply accidental, or if you will, the powers of one or two people to observe something. This is in essence what the first of a category of medications they call immunomodulators. So it's been the holy grail of immunology for a very long time to find a way to help your body heal itself. And that has come up with some dead ends. It's come up with some things that were in fact overhyped, if you will. I have no innate obligation to see something in a hyperblown way. In fact, if anything, there was a much more critical lens of science where you would look at everything and say you need to prove it. LDN has more than proven it. LDN has now well above 1,000 PubMed articles. The expansion of clinical indications has gone from half a dozen to, as I've said, well over 150. These are extraordinary success cases. So we're presented with a problem, is how do you communicate these issues to the people that need to know them in an effective, efficient manner? And I can tell you that the single best way that we've seen is through compounding pharmacies. There are a number of compounding pharmacies in this country, and they have a tremendous ability to educate patients and educate providers. That's a very different world than the Walgreens and the CVSs of the world. We're really, it's really about patient-centered medicine. And that is the perfect marriage with something like LDN, where the single best thing that I can pass on to you that I've learned over the last 5 years of this is LDN, for all of its remarkableness, for all of the patients, thousands of patients who are usually at their wits' end. They've tried all traditional protocols. They have rheumatoid arthritis. They've had it for 25 years. They've tried 8 different medications. They've been through a similar number of providers, and they're not getting the relief from the degree of suffering. The LDN turns out to be a remarkable medication, especially when people are hurting the most. So whether it's mental health, it's depression, anxiety, it could be PTSD, things such along the lines of autism, dermatology conditions, again, are really extraordinary. That Haley disease, some of these incredibly difficult to treat conditions, it's the ability to harness the power of the body. When your immune system is able to be optimized, when you're returning to a much more normal functional state, that's what you're talking about. You're talking about the body's ability. What would your immune system be able to do if it were operating as it should? And in essence, just as a very quick clarification, LDN doesn't cure anything. No one makes those claims. What it really does, though, is it is the single most powerful medication I've certainly seen, medication or supplement, to help your body truly begin in the tug of war between the disease and your immune system. It gives your immune system the upper hand. And so you may have been at a 7, 8, or 9 on a pain scale, and now you can live on this 2 or 3 or 4. We've seen that over and over and over. So I think I just wanted to begin by saying I've had a bit of a privileged position. I've been able to speak multiple languages. I enjoy the conversations and all the interactions with the LDN researchers. But as an example, I can summarize my career path took a turn that will never go back. And that happened when I went to the very first LDN conference that I attended approximately 5 years ago. And the conversations among people there was extraordinary. We had the head of Massachusetts General Oncology, one of the top 10 cancer programs in the country, lecturing, having a discussion with a pediatrician, having a discussion with a pharmacist, having a discussion with the patient. And it made an impression on me that will never go away. That is entirely different than any other conference I've ever been to, where we simply talk amongst ourselves. So if you're a provider, there are ways that Brad can get you those recordings, and I would strongly encourage you to look at those, because if you're unable to attend the conference, it's hard to kind of comprehend the degree of enthusiasm among your colleagues that this medication provides. That is an abnormal situation. We don't usually gather in large numbers to talk about insulin or to talk about penicillin or to talk about any specific new medication. This is an international conference that draws people from all around the world doing exactly that. Just very quickly, to sum up the scope of what's possible, the same lecturer I was discussing, the head of Mass General, indicated something that will stick with me forever. He goes, if this was a medication that was discovered within its patent period, this would undoubtedly be one of the top 5 medications we prescribe in this country. Up to 20% of the US population would have a medically justifiable use to consider LDN as one of its treatment options. So the struggle that is now contained is sort of an artificial one. We are dealing with, in my opinion, the inadequacies of how we do medicine and healthcare and bring drugs to market in this country. We shouldn't, in a way, have to be doing this. It should be self-evident. The weight of the research is so tremendous that I think you as a provider will be very surprised that there's double-blind placebo-controlled studies out of Harvard talking about how LDN is much better at treating depression than standard SSRIs. There are treatments for low back pain where they've been able to get people off of full dose opioids within about 30 to 60 days who have been essentially addicted to opioids for 8 to 10 years. You have a number of these these are not isolated, these are not anecdotal, these are not simply case studies. The problem, as you probably know, is that we simply don't have the funding that it would take to say, okay, we're going to do a 1,000-person, 2-year study on placebo-blind controlled studies. But I would put forward that you don't need to. In all of the medical schools that we've ever lectured about it, it's been very well received. We have, there's approximately 300,000 people minimum in this country that are currently taking LDN. Worldwide, there's 2 million. There's a gathering body of evidence about not only its usefulness, but its lack of side effects. It creates a tremendous clinical tool to add to most of the conditions that you see each day. If you're a patient who suffers from autoimmune, I strongly encourage you to work through your provider and Brad, because what you'll find is that there's likely very good research talking about why you should do it. And there's one of the most wonderful things about LDN, and perhaps I can finish this part of the segment saying most medications are faced with trade-offs. Whether you're a provider or a patient, you're constrained by contraindications. You can't take this medication with that. You're restrained by side effects. You're restrained by cost. LDN is extraordinarily inexpensive medication. It has, in essence, no traditional side effects. What you're doing is you're taking something almost equivalent to a baby aspirin, and what you're doing is it's your body's response. So there are things that you need to know. You need to know how to work through other medications that you're taking. If you're on thyroid medication, you absolutely need to understand how LDN works. If you're currently taking an opioid, we now have ways that we can help you work through those issues on titrations. So basically, any patient anywhere with an opioid, we can now help. But that is such an advance, and from simply 2-3 years ago, that what I would end the segment with is it's vitally important. And I can say this having done, again, several hundred of these lectures, is whether it's one physician or whether it's 250, whether it's simply in an office setting or whether it's Yale Med, there is the need to understand more about LDN than simply prescribing it. You may well have to take this medication for 1 to 3 months before you see a response. And if you're not educated in what that means, you might be likely to give up. And I would strongly encourage you not to. What you need to do is simply work with someone such as Brad, who has been trained, who has been certified in the ideas behind LDN, just on the provider side, the same way. And we're at a point in LDN's growth where that is the single biggest need that I see. It isn't that LDN needs more research. Yes, it does, as it continues to expand. But it's very different than 4 years ago. 4 years ago, there was need for funding. There was need for I wonder if it would work for these cases, for these indications. Now the problem is education. The problem is, how do we get the word out? How do we train physicians? How do we train, how do we get patients aware of possibilities? And I would say that we've learned that it's not as simple as we thought. Just prescribing LDN is not sufficient. So if you've tried LDN and said it doesn't work, and yet you've been on Facebook and other places, or you've seen this and people rave about it, we understand the reasons now. We understand the reasons why now. We used to do 5 doses. Now we do 23 doses. We go things as low as microgram dosing, all the way up to about 6 to 8 milligram dosing. And if there were 100 different people with fibromyalgia, there would be about 60 different pathways to get to success. Not just different doses, but different times. Because again, what we're doing, we're used to what's called cookbook medicine. We have a problem, and we take a pill, and 45 minutes later, we hope it's better, and if it's not, we take the extra strength version, and then that's what we're trained to do. This is really about a slower, more organic process that brings your body's own immune system back to a higher degree of functioning, and as a result, your body is able to deal with and effectively, I would say, you don't eliminate, but you can create a situation where your body is able to reduce the symptoms that you're experiencing because of your disease to a point where you can sometimes forget. And that's the goal, is to create a higher degree of functioning in your life, to live with minor pain as opposed to major pain, and to get about living your life. And so on that level, you have I would say, several hundred, probably up to about 500 of some of the most motivated professionals in this country, pooling their data, looking at ways that they can get the word out, trying to help educate patients. Brad is part of a larger network that's a nationwide network that involves some of the best researchers and the best pharmacists and the best clinicians in the country. And we're really here to try to serve you as a patient, to both introduce it to you and to work it through with you. I think in the end of the day, I always say, name another medication that you can take for a month, nothing happens, and it's perfectly normal. You need to rely on somebody like Brad to help steer the ship and understand that you really are accomplishing things every day, that this takes time, and that the results that you'll be able to obtain, almost always, not always, but almost always, are well worth the wait. And I would strongly encourage the idea of giving it a try, because in the end of the day, you're not really taking much of a chance. You're looking at something that has well-proven science that, if you're a provider, someone like Brad can provide you entire binders full of research that deals specifically with the patient population you're looking at. And that the last sort of safety net underneath everything is that in virtually every case with LDM, as opposed to most medications, the worst thing that can happen is that you give this a 90-day try and that nothing might happen. I would be truly surprised if that was the case. I think we've gotten to the point where our success rate is in the mid to high 80s for almost all patients across all clinical indications. But if you consider that this is where you've been for years, typically in a chronic disease state with mostly mediocre solutions. If you're taking gabapentin and prednisone and a lot of things that you've been taking chronically, you're really just treating symptoms and hoping to get to a better place with your symptom control. LDN looks at it in the reverse way. You're really trying to help your body help heal those symptoms, and that has proven to be an extraordinarily successful approach. So with that, I'll hand it back to Brad, and certainly be happy to talk more. This is the part of things that I truly love. We've been able to help tens of thousands of patients go down this road. So with that, I'll give it back to Brad, and then we can talk some more.
All right. Well, thank you, David. I was going to share my screen here and go through a couple slides here and give you a little bit of info about us. And I assume that everything is still visible to everyone for our images and things. And I'm going to open it up here for any questions or comments that people have shortly. But, much like David said, my journey as a pharmacist has been one that's been rewarding to be able to help provide patients with solutions. And one of the greatest things is to be able to share and educate things with people that have never had the opportunity to find a solution when they've been looking. And it is not uncommon for me to talk with a patient who has chronic pain in some fashion, whether it be fibromyalgia or lower back pain or any number of rheumatoid arthritis situations, and they've seen multiple doctors and tried multiple drugs, and they don't want to be on opioid medications that could make you drowsy or cause constipation. They're looking for a solution to get their life back. And it's been very exciting for me in the last couple of years to learn more about how LDN can work for patients and with patients, but it's been equally extremely frustrating trying to help educate providers to help them understand that there are opportunities for patients that maybe aren't the most mainstream that they've learned at a conference or learned in med school. So everything David says, I really echo. Knowledge is power, and sometimes it just takes time for that wave to get rolling so that you can see how more and more people can pass around that information. It's kind of like a crowdsourcing type situation. So, September, if you weren't aware, it's the last day of September, but it's National Pain Awareness Month. And it is absolutely staggering, the number of people in the United States alone that are suffering from chronic pain. 40 million adults. That's a lot of people. That's an enormous percentage of the population. And I guess I would challenge you to think, do you get out of bed in the morning and have an ache or pain, or are you worried about how maybe you feel is going to impact you and your quality of life for the day? Are you going to be able to go to the grocery? Are you going to be able to pick up your grandchild and hug them without pain or without worrying that you're going to hurt yourself? These are questions we get in the pharmacy every day. And it's very distressing at times to know how pain can affect a person's well-being, especially their mental state, and how when they suffer so much, the impact it has on them. So, pain comes in many different shapes and sizes. We talk about lower back pain, we talk about arthritis and headache and fibromyalgia. Those are probably the four biggest things that we get questions about in the pharmacy all the time. And we're so accessible to patients. You don't have to make an appointment to come in and talk to us at the medicine center. You can call us, you can walk in the pharmacy. We even have set up a situation now on our website where you can do a Zoom meeting like this with us if it's more convenient for you and you're concerned about maintaining, low contact type of things. So we're trying to provide more modalities for consultations for patients. But the bottom line is chronic pain cost our country and our productivity and our healthcare system a lot of money, hundreds of billions of dollars. And not to mention the fact that nobody wants to be in pain and suffer. So one of the things that's exciting about LDN is the opportunity to share this knowledge, and hopefully the more people we can share it with, we can get the message out that there could be a solution for you that could really help change your quality of life. And Bill Gates says it best that power comes from not from knowledge kept, but knowledge shared. And it doesn't do me any good if I know that there's a potential for a medication or a therapy or a treatment if I don't share it with our community. And that's the goal of webinars and meetings like this. So David gave a quick overview of where LDN came from. And David, by any means, jump in at any time. But, I wanted to share that, naltrexone is an FDA approved drug. It is something that's been on the market for decades. There's hundreds and hundreds of studies about how it was used for addiction and alcoholism. And I don't want that to scare you. I can tell you with some of the providers that we've worked with, just the indications for naltrexone kind of scare them. They're afraid that they can't prescribe that for their patients. And that's not the case. We're talking about the same medication, but we're talking about drastically different dosages. So 50 milligrams, we're talking about 1% of the dose, maybe even smaller when we talk about 1.5 or 3 or 4 milligrams, or maybe even 1 microgram, which is even smaller. But the medication's been used across a wide variety of situations. There's been studies for anything from obesity to autism. And the most exciting thing is that Dr. Bahari took on a hunch. He was able to see how this medication worked to help boost endorphins and modulate the immune system in a group of patients that had HIV, and they were not doing well. But this one key discovery made him think, if this medication can help boost these patients' endorphins and help boost their immune system to extend their quality of life, but they have all these side effects from it, maybe there's a way to take that same medication and reduce the dosage and still get the benefits of boosting the immune system and modulating it and helping it boost those endorphin levels to get those key results we want without the side effects. And that's what most of the research that David has mentioned has been focused on. Big time schools you're going to know, and renowned medical organization from Stanford to Penn State to Harvard to Yale Medical School. There's a number of these organizations that have done studies on this particular medication over a wide variety of patient populations. And you can see that now in 2020, there's over 1,000 articles that have been developed and have been directed toward trying to figure out, why does this work? You may want to know why you had to come and tune into this webinar to learn about this medication. There's a couple reasons. One is just sheer pharmaceutical economics. You're not going to see fancy colored video commercials on TV because the drug companies can't repatent this medication and put a fancy name on it and sell it for $25 a pill. This medication's been off patent for years, which means that it is available at a lower cost in the marketplace. It is very affordable. The great thing is that a compounding pharmacy like us at the medicine shop, we are able to customize dosages for patients in a wide variety of strengths. David mentioned 23 different 23 different strengths right now. I mean, it's amazing how we can customize this medication that is an FDA approved drug. So it's one of those things, we can tailor that dose when we work with your provider. And it's just a matter of targeting and finding that right dose that'll work for your particular condition. Everyone has a little bit of unique body chemistry. And as a result, sometimes your condition might require a little bit more duration or a little bit more tinkering, for lack of a better word, to dial in on what you need. So it's really important that you realize that, much like other situations in healthcare, this is a marathon sometimes and not a sprint. My favorite thing is when I talk to a patient that just started LDN and they've had results in the first week or two. It's a little more challenging when it's taken a patient 6 months, but then they wake up one day and bang, it's like all of a sudden everything started to click. So I encourage you to ask questions of both us at the pharmacy and also your providers. We have a wealth of knowledge we can share with you. And one of the most important things is, why does this work? What is the mechanism that we think it works? And how about, David, I let you handle the mechanism, because I know you've talked with Dr. Chopra in the past. I think I lost David for a minute, so I'll continue here. Excuse me.
I apologize.
Gotcha. Okay.
Yeah.
No, it's okay.
I've learned through being in Zoom, as we've all been introduced, I've learned the automatic mute. So I apologize.
No, that's fine. I didn't cut you off guard.
It's something I think, I think a big part of my role is translating, and I have truly seen and experienced on every level. And maybe worth noting, for 4 years straight, the third Thursday of every month, I would do a patient seminar. So you're talking about, hundreds of seminars and thousands of patients, and just by listening, you understand what some of the natural questions are, and they're very good questions. It is, how can one medication be good at so many different things? And from a provider point of view, it's very similar. It goes against the grain, and there's a natural hesitancy to embrace something that perhaps sounds too good to be accurate. And I think one of the best roles that I have seen is again, for some of the providers, say if you were in gastroenterology, you will know the name Leonard Weinstock. He's one of the top 10 in the country. He's also one of the biggest proponents of LDN in relation to GI conditions that there is. He's done extraordinary work with Crohn's disease and ulcerative colitis. And Brad has access to, the PowerPoints that he's presented at these conferences. I have a chance, I know him. I know him to the point to have had conversations where we go, how this has altered his career, where you don't expect a medication like this to come along. Because we're used to incremental advances. We're used to, the traditional orthodox methodology of here's the symptom, and we're trying to make a 10% marginal improvement over an existing medication. This turns a lot of it on its head. And it for some patients, it has been what they've been waiting since they've acquired their disease or condition to see. And I think that so the danger in my mind, after seeing all of these patients, all of these physicians and different providers, is it's not overestimating, it's underestimating. I really truly believe that LDN is the first of this class of immunomodulators. 5 years from now, we may be talking about LDN plus some other medication. But it is truly taking the field and turning it around. And one of the best ways to understand it is the mechanism of action. And it is interesting that even in the time that I've been involved in LDN, approximately 5 years, we've gone from one mechanism of action to approximately 5. And just as a real synopsis way of looking at it, because I think that there's a danger of getting lost in the minutia, is that what Dr. Bahari, whom Brad and I have both spoken of, because of his stature, because of who he was, when he was the person that was the New York City commissioner to try to help patients with AIDS, back when there was no triple cocktail. It was, in essence, a death sentence. And he noticed this thing that Brad and I have related to, that in animal models, taking 1% of this very well-known medication that had nothing to do with autoimmune disease was now helping to restore immune systems. And it was in essence the cart before the horse. So we're used to, in science, it is, very long, slow slog, and that we, over the course of 8 to 12 years might develop a new positive indication, and then we spend another 5 to 10 years, trying to isolate and go for FDA approval, and then we roll it out onto the market. LDN was the exact opposite. It worked, but we didn't know why. And again, because of who Bahari was, everyone of the colleagues around the country offered to help. And if you're interested in a really interesting history of science thing, go to YouTube, Google Dr. Bahari, and you'll see about an hour-long video of a man in a long white coat talking to you, and you think it might just be, boring as it is, and it is absolutely riveting. I find it something extraordinary. He really transformed. I believe history will look back on these advances, and his will be among them, that stands out 50 years from now, because no one had thought to think the way he thought. And what he did was follow it up scientifically. There's no such thing as just saying, here's a good anecdote or here's something. He sought out to prove the mechanism of action. So when they looked at all these patients that had the best survival rate of anyone in the country, and they did every blood test known to man, the results came back that the only indication that was different is their endorphin level. So the very first mechanism of action that we should be talking about is their endorphins. That we used to think their endorphin level had tripled. So as an example, if you take LDN in the traditional way, where you would take what I equate to a baby aspirin before you go to bed, by the time you wake up, it's gone. It has a very short lifespan in your body. About 4.5 hours is its half-life. So in essence, what you need to understand is it's not the medication that is doing the good. We are used to take a medication that dulls your pain. Take Pepto-Bismol, and it helps relieve your diarrhea symptoms. Do things. What LDN does is its effect on your body is waking up your body's own immune apparatus. So it's true. You wake up in the morning and the LDN's essentially gone out of your body, but your endorphin levels have tripled. And that was an unexpected finding. We used to think of endorphins as, runner's high, or we're all used to, what it means to feel an endorphin rush. What we didn't know is that they were critical to the running of your immune system. So one of the most interesting science aspects of this is people with autoimmune disease are grossly deficient in endorphins. So multiple sclerosis, about 22% of normal. Rheumatoid arthritis, about 18% of normal. There is a cause and effect going on. And what we've realized is that being deficient in endorphins, by definition, means you have a dysfunctional immune system. By restoring the level of endorphins, you are in essence elevating the immune system and entire ability to operate. So that's a simplistic explanation of one of the primary mechanisms of action, but I hope it makes sense to people, because you're not treating a symptom. You are in essence treating your immune system. And the way that we now learned that was completely unexpected is that you're addressing a deficiency in endorphins, which help to control and in effect modulate all of your immune system. So there are several other mechanisms that I think are one of the best things that I can tell you about this PowerPoint from Dr. Chopra. He's an exceptional individual. He's, again, one of the top 10 pain people in the country. He's a specialist in chronic pain. He's a product out of Harvard. He's one of the directors of Brown Pain Management School, and he is a fierce advocate of LDN in the treatment of chronic pain. So as a need, and I know him well to the point where I asked why he produced this particular PowerPoint, and he goes, he was tired of being asked by his colleagues to explain how LDN worked. And so he put together an extremely masterful, I think, PowerPoint about it. Brad can help relay it to anyone who's interested. It goes through these other mechanisms of action in detail, but in essence, what in the bottom line of all of it is the ability, an exceptional ability of LDN to reduce inflammation. And for, again, for the providers and many of the patients who have looked into the research, there's an idea behind inflammation that inflammation is a catalyst for many of our biggest disease states. So if you look at cardiac disease, if you look at cancer, if you look at autoimmune disease, one of the believed common bases of all of that is long-standing inflammation within the body. And what LDN does is, in a very rapid time frame, the ability to control and reduce that inflammation. Very quick example, I've had the same primary care practitioner for 25 years. I did not let her know that I was taking LDN, and I take it as a preventative. I have the markers for ankylosing spondylitis. I'm HLA-B27A positive. For any of those you who know, who can relate to that, ankylosing spondylitis is a horrific disease. My goal is to never develop the symptoms of it. And I began taking LDN after doing the research. And she remarked all on her own, and she showed me a graph. David, I have your graph of your inflammatory markers going back 15 years. And she goes, I don't know what you're doing, but they're near zero. So things about sedimentation rate, CPR, and a lot of the other indicating markers. She goes, there's very little inflammation in your body. You know, what are you doing? And we had a discussion about it. And that was intrigued her to the point where now she's treating many of her patients with LDN because of this idea that the mechanism by which LDN works is this broad-based reduction of inflammation that has all these positive consequences as related to it. So that was probably a longer explanation than many people might have been wanted, but I would recommend strongly going through BAD to get the PowerPoint. It will help answer any of the detailed questions you may have about that explanation, as well as the three other primary mechanisms of action.
Excellent. Excellent. You know, it's not just fancy scientific literature that we have either. There have been some really nice high-profile media publications about low-dose naltrexone. Just last September, there was a really great news article on NPR, and it highlighted this woman's journey, much like I alluded to when I began talking tonight, that this particular woman had been to multiple doctors and tried multiple medications and just hadn't found a solution to her problems. And low-dose naltrexone had helped her get her life back. I encourage you to, this is only a 3-minute news story, as you can see, and I have a link on our website. If you go to our website at medshoprx.com/low-dose naltrexone, there's a link to this article and the next article that I'm going to show you too. But I guess my point in showing you this tonight is it's really encouraging to see that it isn't just us science guys that are talking about this in these medical journals. NPR is making news like this accessible to our community and our country. AARP magazine, much like David just mentioned, had an expose last November on inflammation's impact on the body, from the brain to the heart and arteries, and asthma and cancer and obesity and arthritis. Again, you know, we have some more information on our website that you can certainly take advantage of, or we can help share with you after the program. But it's encouraging to kind of tie some of these things together with LDN's impact on inflammation and inflammation's impact on chronic disease. And that's something that I think is really important for everyone to be aware of. We're striving to have the best information available we can. And I think the more information we can read and share, I think it'll help not only us as providers and medical professionals, but also patients, so that we can give you the best information possible. You know, the great thing for my benefit, my journey, in addition to talking to patients and learning about LDN from the patient side, was I was able to be exposed to a international conference in Portland. There's just a wealth of knowledge out there that many practitioners have come together to join and share. Um, and we're looking forward to having a program next year after the pandemic's over to get together again and share this information. But there's so many great things that we have the ability to share with each other, and it's like crowdsourcing. The more we have the opportunity to share that information, the better. I thought you might like to see some examples of some patient results. In the group of pharmacists and providers that I am working with and learning with, which David has been a huge part of that. But one of the great things is we've been able to kind of aggregate and put together some surveys with these patients. And so we took, we took a bunch of patients. We asked them questions. We simply asked them to give us results based on some open-ended questions, and they provided them. So, you can see that it was maybe more male than more female than male here. And these patients were on very basic dosing strengths. In the beginning, some of the studies that are out there talk about patients just using 4.5 milligram across the board. And you can see that half the patients were taking that. We're finding now today, as David mentioned earlier, that there's a lot of patients that need a more customized dose, and that 4.5 milligram is probably not going to work for everybody. Your dose could be very specialized. But that being said, the great thing about all this is 87% of these people said they had little to no side effects. That's pretty extraordinary. When's the last time you saw a drug manufacturer's ad on TV for a medication and you didn't have to listen to the guy at the very end talk about all the side effects that they had, and kind of make you wonder, oh my gosh, is it safe to take that? The most common side effects that were reported, and they were minimal and resolved after about a week at the most, were some people had insomnia, some people had some vivid dreams that seemed very real to them, and some had some headaches. But overall, the side effect profile is very low, and we don't traditionally have a patient stop their LDN therapy because of a side effect. So that's something I think is very encouraging for everybody to be aware of. But more encouraging is all these patients commented on what their doctor ordered the medication for. And it's pretty staggering. You look at this list and you're going to probably think, all right, are Brad and David talking about some type of snake oil product or something here? But really, all of these conditions on the screen, they all have some level of inflammation as their foundation. And they all have some complication which results in, whether, if it's not inflammation, it could be a result of other chronic diseases that have contributed to exacerbating or making their condition more pronounced. Lyme disease, chronic fatigue, those are things that are very challenging to deal with and treat in this day and age. Fibromyalgia affects not only muscles and joints, but, it can really affect your mental outlook on life. It's just fascinating to see all these different conditions. We didn't ask the patients to pick these. The patients offered these, and they went to their providers looking for solutions. And so it's just really exciting to see the wide breadth of options that are here for patients. But 84% of the people on just these basic, simple dosing protocols, before we knew what we know now, 84% reported a success rate. I wish I could have 84% of our patients that come into the pharmacy be that happy with their medication therapy for their disease state. It just doesn't happen with cholesterol, and it doesn't happen with blood pressure, and it certainly doesn't happen with patients who are struggling with diabetes and their blood sugar. So if we could help those 40 million chronic pain patients that we mentioned at the beginning of the program in the US, and help 84% of them control their chronic pain on some level, that would just be awesome. And I think that it would be something that would be very valuable to everyone and their quality of life. So I've got a couple testimonials here, and David, I don't know if you want to jump in here and talk about any of these, because I know that there's a couple people in this list that you know personally. So by all means, if you'd like to, please go ahead and I can advance the slides as they need to be.
Yeah, I would enjoy that, and you know, I can tell you that one of the common grounds that we call it sort of a kindred spirit, if you will, between, doesn't matter whether you're a physician, a pharmacist, researcher, where you fall on the spectrum, and even patients. Why are we all becoming such advocates for this medication? And I can tell you, it is one of the least expensive medications I've ever heard of. It is something where there's a bit of a learning curve to it to do it well, so it requires effort. It is no small task to become educated in LDN and to come to the place where Brad is at as a real expert in this. And most of the people that I know in the field who are going and educating are doing it as volunteers. I've been a number of different medical schools in different situations talking about this, and it's always the same. There is this initial skepticism that is then replaced by okay, I'll give it a try. I understand that it's safe, but I won't expect necessarily much if you're a provider, say trying half a dozen patients and having 3 or 4 of them come back with these remarkable results, to wanting to understand more, there's sort of this positive snowball that happens, and then you begin looking at other patients, and someone like Brad or myself will field phone calls like, well, is it effective for this condition? And in most cases now, fortuitously, as opposed to say 5 years ago, we can point to specific research by very high quality researchers that give you this confidence in doing so. And from a patient side, it becomes, one of the things that I learned, and this is not something that was intentional. I think in the second year of doing all these seminars, which was truly just as a patient service, I asked someone, I surveyed the audience, how many years and how many physicians and how many medications has it taken for you to get to this room? And it began a tradition that I do that at the beginning of every seminar with patients. And I think the record was 28 years, 15 physicians, and about 16 medications, from a wonderful elderly woman with rheumatoid arthritis who said, and I'm no better off than when I started. And so it's almost like, much of chronic pain is invisible. I think I had a woman go, I wish I just turned purple, or I had a broken leg, so that people would be able to see how much pain I'm in every day just to function. And that this idea of what it means to succeed is so different for each one of us. For her, it was just, wanting to be able to hold her grandchildren. I mean, and I know that I'm not at that phase in my life, but I can understand what it would mean to someone to have to think about that every time they went to pick someone up, or every time that they were, they couldn't participate the way that they wanted to. It is no small thing, it's a huge thing. And so these quotes are really about patients who describe their initial state, which was a life compromised by pain, and that's just a common thread in all of it. And kind of as Brad goes through it, there may be the one, you see things like able to function only at 30-50% of normal life, and chronic. Now I do think the one on the bottom is worth pointing out, and as Brad comes to the end of the presentation, you'll see this is a woman I know personally. She was a woman, and maybe it's worth just telling the one vignette of a story. This was a woman who was a single mother, 3 kids. She was a secretary, and that she developed this incredible psoriasis, some of the worst I've ever seen. It was to the point where she was unable to bend her hand, so she was fired. She lost her job. She couldn't type. She couldn't write. And so there is no such thing as a disease. It's always a life, or even a family. But I wanted, people who have taken gabapentin, you'll recognize 900 milligrams of gabapentin 3 times a day is an extraordinarily high dose. But I did want to point that out so that maybe as we go through some of these others, Brad, you can begin to see what the before and afters are like. I think that's, oh, yep, so Now, here she is just saying, talking, and we're going to see pictures in a minute, but she had tried everything. I know her story. She had been to Mayo Clinic. They basically told her, here's a corticosteroid cream. She had been told, you're going to be living with this, that there were no other options. And much like most people's LDN path, it was knowing somebody. Somebody recommended, and they kind of dragged her to a meeting, and they said, you know what, you have nothing to lose. This is well worth a try. So in a little while, you'll see a picture of what had happened to her skin. But basically, the short version is that, well, she had full resolution, but maybe we can kind of fast forward through a lot of this just because of the time. But I think it's well worth the degree of, sorry,
It's okay. I think we should see the picture.
okay. So this is her. And again, she's just such a sweet individual, and you can't even really see it from this. But imagine sort of having a claw for a hand, and then this is how she described it. And again, years worth of therapy trying to deal with this, and suddenly it just something that small took over, seemingly that small took over her life. And then here was the picture after approximately 8 weeks on LDN therapy. She was on no other therapy. She had dropped all other medications. She'd basically given up. So if you want to understand why providers are so fiercely, advocating for this medication, why patients become patient advocates, it's because of stories like hers. They're usually, LDN is its best when the condition is at its worst. And she actually went back to her physician at Mayo and made somewhat of a spectacle of it and said, these were my pictures from before, and here are my hands now. And he became, to his credit, one of the biggest uses of LDN in Mayo Clinic. And so he routinely uses it for dermatology uses. But she also, you wonder what motivates people. She would get up on stage often and ask at these meetings. I would open it up to patients, and anyone who wanted to talk was welcome to. Half a dozen to 10 times, she would routinely come, a year later, to try to help other people who are in the same boat. Nothing is more convincing than having someone who's going through the same thing you are get up and ask and say, please just do this, give it a try. And so I think that's behind a lot of what Brad and I are trying to communicate is, you don't have to understand every bit of the science. You don't have to, I mean, if you're that oriented that way, then tremendous. But really it becomes a why not? Why not try it type argument. A lot of it is trusting in the credentials and experience of the people who are pursuing this therapy. Another is realizing that your worst case is basically you give this a solid try for about three months or so. And I think you'll be surprised. Virtually everyone that has been willing to engage on that level has been pleasantly surprised. So we wanted to show you a single case that was fairly dramatic.
Okay. I guess I wanted to touch on a couple things. I know we're running kind of late, but I wanted to take some questions. We've had some questions from patients, but I wanted to kind of highlight some other educational opportunities. There is the LDN book, Volume 1, and very soon to be Volume 2 coming out from the LDN Research Trust. We have those available at the pharmacy, and the LDN book, Volume 2, is shipping as we speak. So we'll have those very soon. We want to try to provide any education support we can for patients and providers. There are a lot of customized dosage protocols. So I think that's something that it just opens the opportunities to help with a number of different conditions. And it's really exciting to be able to talk about that. We've had a couple questions. I've had one gentleman post some things up in the Q&A section. If you have other questions, by all means, you can post them up. One person commented on what happened to the other 16% of the people in that study that didn't have success. And he said his guess is they stopped taking it. I'm kind of wondering if you're not right. I mean, I don't want to be so arrogant to think that this will help everyone, but I do believe that if you've tried LDN and failed, we need to reevaluate the dose and the dosing schedule and maybe the duration of time that you tried it. I'll be the first to admit I'm the most impatient person there is. You know, we all want immediate gratification, but sometimes, especially with chronic conditions, if you've been battling psoriasis for years, you know, her 8-week results are overwhelming. You know, it may not be that fast for you, in all fairness. It could be faster, but I don't know if you have anything to comment. You mentioned earlier, David, about trying to dial in correct doses and therapies for patients. Is there anything else you'd like to add about that?
Um, only that, you know, the value in I think what I've seen is more related to how correctly the field has grown, and in that there was for those of you who've studied LDN or feel like you've tried LDN and it wasn't necessarily successful, you know, Bahari, who came up with this, really was thinking that everybody should wind up on 4.5, and what you got was what you got. And the success rate there was about 52%, which is no small accomplishment. Remember, these are people who have what they're in medicine is called refractory. In other words, they don't respond to the other therapies they've tried. So any provider would take that hands down. What's grown since then, though, is the idea that we don't just try to get people to 4.5. In fact, when we did an analysis of about 5,000 patients, less than 30% of them were actually at 4.5. These are people who had all succeeded. So what happened was a realization we needed to change how we dose things, and we changed. So as an example, what Brad can speak to very eloquently is the summarizing of not, and that I would distinguish between anyone, even pharmacists who haven't gone into the training or providers who haven't understood that, is that you want to get the success rate into the high 80s or almost 90%. You need to be able to differentiate how you dose it. So your dose may be 2 milligrams, my dose may be 5 milligrams, but someone like Brad could help each one of us get to that success level.
Very good. So one of the things we are trying to do is we are really just trying to be available to educate patients on the opportunities for LDN. You know, I've had the luxury so far of being able to speak to the pain support group at the Cleveland Clinic. There have been some other programs we've done for support groups around Northeast Ohio. So, you know, if you're a member of a support group and you have a focus on pain or autoimmune diseases that you think might be interested in hearing our message, we'd love to be a part of that. You know, I guess my next webinar on this subject, we're going to redo with a slightly different twist at the end of October. And I'm hoping that we can have some different information. There's new information coming out all the time. And that's one of the most challenging and yet the most exciting things about the promise of low-dose naltrexone. Whether it be in a medical journal or a news release, or even if I've talked to one of my pharmacist providers or a resource like David, it's so exciting to be able to share what worked for a patient and their particular situation so we can leverage that knowledge and share it with others. So I'm really hoping that if you have other questions, you know, please post them up here before we finish. I just had a question, David. How about this? How would you know when you have the right dose? Do you care about, can you address that for a patient who maybe gets started on a particular dosing schedule and is trying to find the right path?
And that really encapsulates, I think, the need for specific education about it, because what was happening in the past was, again, we went to a pre-designated dose and said, well, we really hope this works well. And what happens is some people would say, this is amazing, I've been waiting for this, and they would rave about it, and then other patients would get no response. And so now we understand that there could be as little as a quarter milligram or half a milligram difference in success or not. So imagine this curve like this, a parabolic curve. And there's a window where if you're too low, it's not helpful to you. And if you're too high, it's not helpful to you. We're not used to that in medicine. What we're used to is, you know, more is better, and you know, wait 45 minutes. So again, when will you take something for a month and it be perfectly reasonable? LDN. However, how you judge success is also part of how we're getting better at this. So in the past, it was just sort of, go to a dose and then, again, kind of hope that things go well. Now we know that, as an example, Harvard did a study showing that with depression, LDN was incredibly successful, but they would say that you would need to take a very, very low dose, say 1 milligram as opposed to 4.5, and they would recommend taking it twice a day, and that was far more effective than taking 4.5 milligrams in the evening. That's the kind of advanced analysis that we now have for many, many of the disease states. So we can tell you both from the research and clinical experience that we have a much better idea of what to tell you, what to expect. So that's number one. Number two is it still is essentially based on your symptoms. So if you have specific things, if you have chronic pain, the ultimate test of whether it's working is, do you have a reduction in that pain? Now we can tell you that, say with dermatology and GI conditions and chronic pain, that it is a higher dose for longer periods of time. So what we would often be able to tell you now is, please be patient. 8 out of the 10 of the patients with similar conditions, if they simply continue taking this dose for 30 to 60 days, we'll begin to see results. So the ultimate arbiter of success, the yardstick of success, is, yeah, you will notice your symptoms reducing. But I think that's got to be informed by someone like Brad, who can funnel all of the research and all the experience we've now gained. It's called clinical indication specific dosing, but what it really means is that we have a guidebook for a protocol to help you with each condition to get to success.
If I might add to comment on that, I've had patients tell me that when they do a titration, for example, so, maybe they start on a 0.5 milligram and the doctor has them take that for a week, and then they increase it to 1 milligram. Maybe they do that for a series of 3 and 4 weeks. And once they get to 3 milligrams, they start to see some results. They notice that they've got some reduced pain, or maybe they can, walk a further distance, or they just feel better. Sometimes we'll have patients tell us that when they make that next jump, if their protocol called for it, to the next step up, sometimes they lose all the benefits for there. And it's interesting because that is something we try to make sure patients are aware of, because if you have one of those moments where you were feeling really good last week and your dose changed this week and you don't feel as good, then we need to work together to see if we need to dial you back to that previous dose and see if you return to how you felt and you have those benefits. So that's something that can be really valuable, to be monitoring your symptoms. And I like to tell patients, when they get started, they ought to take a symptom inventory, and they ought to think about how they feel on a daily basis. And, if it's arthritis, are they stiff in the morning, and are they stiff all day long, or, what is going on, so that you can look back at that in a week, 2 weeks, or 3 weeks, and compare how you feel today to how you feel then, and see what kind of progress you are making. So just had another question come in, David, about depression. And the questions.
Okay, I apologize.
Yeah, the question's really interesting. Do you see it on your screen? I guess I'm not sure what you see. Okay, okay, go ahead. I'm sorry.
I think it's fascinating, and that is, again, encapsulating how rapidly the field has evolved. We used to just say, well, you can only treat one primary thing at a time, and that we would say, obviously the CRPS is more relevant to what you're going to have to deal with. By the way, there's extraordinary papers on complex regional pain syndrome, and Brad can get this to you. There is Chopra has put out a paper along with Mark Cooper with just advanced stage CRPS that was unresponsive, refractory treatment protocols, and they go through a very detailed analysis of it and have extraordinary both results and documentation of the results. So one of the upsides of the quality of the researchers that we're working with that are promoting is the wrong word, advocating for LDN, is that they understand the need to provide objective proof to their colleagues. So these are not simply anecdotal cases. The CRPS in particular has half a dozen major papers associated with it that are all replicable, and that show extraordinary results. Now, what you're getting at is an interesting aspect that the field demanded an explanation, that like this happens more. 82% of all autoimmune disease, I believe, has accompanying anxiety and depression. Now we understand the reason why. They're grossly deficient in endorphins. So there's an endogenous anxiety and depression aspect to autoimmune disease. Now, what if your autoimmune disease wasn't responding up until about 3 to 4.5 or even 6 milligrams? The Harvard paper would advocate 0.5 to probably about a max of 2 on their dose response curve to depression. And what has resulted is a thing called hybrid dosing. And so it probably in the last 12 to 18 months, I mean, before that, it was simply not heard of. It was that you had to make a choice. Now we realize that we can treat simultaneous comorbidities with this differential hybrid dosing technique. So that you're taking advantage of the short half-life of LDN, 4.5 hours. So an AM dose, which by the way is the key dose for all mental health conditions. The Harvard paper in particular makes it clear that if you're choosing between AM and PM dosing, choose AM. Now that's doing a lot with circadian rhythms, it's doing a lot with endorphin production. We all know between 2 and 4 in the morning, that we have this big burst of endorphin production. However, we have 3 others during the day and during the rest of the 24-hour cycle. So what happens is you can have a low, in answer to that question, Robert, that's a classic example where you might have a 0.5 milligram dose in the morning and a 4.5 milligram dose in the evening. And what happens is that you're able to address simultaneously this idea of depression. And again, all mental health conditions, including autism and a lot of other things, seem to be really centered around what we call the left shift. So if you take a 0 to 6 milligram curve and you're centered around 3 milligrams, mental health, thyroid tend to be left shifted. Dermatology, chronic pain, some of the more traditional autoimmunes are right shifted. So we actually did a study where we had about 400 fibromyalgia patients. We looked at it, this was just with our own set of patients. Over 80% of them indicated, self-reported that they had a depression or anxiety component. After the Harvard paper came out, we worked with the practitioners and we advocated for this low morning dose. It was one of the, just simply adding a low morning dose. They were on average about 2.8 milligrams is the median dose for responsiveness for fibromyalgia, but it's centered around the evening dose. And it's only worth the 30 seconds to go through it, but that's an example of why understanding how this dosing works. As an example, LDN is very good at producing a significant increase in phase 4 sleep. Now, so often people will take LDN and they'll say one of the first things they notice is, well, I just feel better. I still have my pain, but I feel better about having the pain. And they'll also report improved sleep. And they went back and looked at it and they put people on sleep monitors and looked through the thing and they realized, my gosh, they got about a 30% increase in phase 4 sleep. And one of the triggers for fibromyalgia symptoms is a deficiency in phase 4 sleep. So you have this sort of cause and effect, but again, it happened backwards to normal. We noticed an improved effect. We went backwards, we researched it, we figured out why. We took those patients that reported the anxiety and depression, advocated with their practitioners to put them on this 0. There's a mental health protocol. So Brad can talk about dosing templates. There's actually, you can check off a box because a lot of this dosing is getting more sophisticated to the point where an individual practitioner might have a difficult time keeping up. Checking off the mental health box allows you to go, okay, 0.5, 1, 1.5, and 2. And I think it was the single best thing we ever did as far as like patient satisfaction. I think we had mid to high 80 patient-reported success rate with a decrease in depression and anxiety while simultaneously treating their fibromyalgia pain with this hybrid dosing idea.
Thanks, David. That's really valuable. And I think, like Steve Jobs would say, you just have to think different, because there's a lot of different ways that we can help patients by adapting different dosing and different dosing schedules. Some of it's trial and error, but a lot of it can be done just in a fashion of trying to make, just trying to find a path to get through their problems. And, it's one of the advantages we have at the pharmacy. we can help listen to your problems. Sometimes you might feel like you're rushed when you go to your practitioner, or maybe right now during the pandemic, you're stuck and you can only do telemedicine. There's a number of different ways, but our goal is to provide education and communicate with you the best we can. By all means, please feel free to call us at the pharmacy to ask questions. I'm going to be sending some follow-up information to you after the program tomorrow. So if you have questions, don't be afraid to email me back and we can talk about them or schedule a time to get together. But I really think it's important that you expect more from your provider and you expect more from your pharmacy, because we all have the opportunity to work together, to learn together. It's just a matter of trying to connect all the dots to make sure we can meet the needs that you have. So, David, do you have anything in closing?
Just that sort of it would be hard to overestimate the sort of the passion, if you will, on the part of the professional community about this medication, and that may be news to some of the providers that are listening. But I can tell you that I went through the same exact process. It was, I was made aware of it by a colleague at Yale, and I went to the conference, and it was something that changed my career path, and that I became aware of a much larger community of very like-minded professionals who were maybe for the first time advocating in a way that they never advocated before, and it's turned out to live up to every expectation that I hoped it would. It is something that I think, in 5 years we'll look back and wonder why it took us so long. And in the meantime, whether you're a patient or provider, I would truly say that every bit of research that I know of, every bit of clinical experience, every bit of, now we're, between myself and close colleagues, probably 20,000 patients. We've seen personally well enough to tell you how they've responded, how well they're doing, what they're doing. It's always worth the try. And I think that you should go in with the expectation that it will help, because in virtually most cases it should.
Excellent. Well, we appreciate all of you taking the time out of your busy schedules to join us tonight. I encourage you to continue the conversation on our Facebook pages or privately over email to me, or even on our website. So by all means, give us a call if you have questions. We'd be happy to work with you and your provider to help share the knowledge. And I'm grateful, David, you could take time out of your busy schedule. Thank you so much for joining us. You had a wealth of knowledge to share, and it's been really rewarding to be on this with you.
Oh, my pleasure.
Okay. Everyone, have a great night. Thank you very much.
Take care.